The anterior superior alveolar, or ASA injection, is an infiltration type of injection that innervates the pulpal and osseous tissues, periodontal ligaments, facial gingiva, and adjacent vestibular mucosa of the maxillary anteriors, that is, the canine, the lateral, and the central incisors. While identical to the infiltration demonstration, the location of the nerves and thus solution placement will anesthetize a broader area, thereby avoiding multiple needle penetrations. Palpate the canine eminence and canine fossa, which is the slight depression located just anterior or medial to the eminence. Place topical at the mucobuccal fold of that area for at least 1 minute. While the topical is in place, use both hands to obtain and ready your syringe, making certain that the bevel is toward the bone and the large window toward the operator. Follow all steps and procedures listed in the video clip entitled Basic Steps in the Administration of Local Anesthesia. A 25, 27, or 30 gauge short needle works well for this injection. The penetration site is at the height of the mucobuccal fold at the canine fossa. To gain access to the site of penetration, gently retract the tissue, pulling the tissues taut while lifting the tissues away from the maxilla. Be sure that the patient's head is tilted up and back in order to enable you to have good vision and easy access. Clinicians tend to have less stability in this area because there are no surrounding tissues to help support the syringe. Use your middle finger for an extra fulcrum if you need it, or just use a tripod fulcrum if you feel stable. Remain parallel with the long axis of the tooth and insert approximately 3 to 6 millimeters, depending on the apex of the tooth. Aspirate at the deposition site. It is slightly more difficult to aspirate in this area than other areas of the mouth. Be careful not to remove the syringe from the tissue while applying negative pressure to the thumb ring. A minimum of 1/2 of a cartridge over a period of not less than 30 to 45 seconds should be deposited. The volume will vary depending on patient factors and planned procedures. Remove the needle gently and make it safe by recapping properly. Potential complications from this injection are minimal. There is the possibility of discomfort if periosteum is contacted. Be sure to stay parallel with the long axis of the tooth to avoid touching the periosteum. Ballooning of tissue may occur in this region. Also, it is possible to see some hemorrhage at the site of penetration. Incomplete anesthesia can occur at the midline with the ASA as a result of cross or overlapping innervation of terminal nerve fibers from the contralateral side. To achieve adequate anesthesia in these instances, administer an infiltration over the central incisors of the same side.
Supraperiosteal or maxillary infiltrations are very useful injections to anesthetize individual maxillary teeth, be it an incisor, canine, premolar, or molar. Each maxillary tooth receives pulpal innervation from small branches of the second division, which is the maxillary division, of the trigeminal nerve. The maxilla's alveolar bone is porous enough to allow anesthetic solution to diffuse through the bone to the terminal branches of the anterior, middle, and posterior superior alveolar nerves. This simple method achieves profound pulpal anesthesia in a very localized area. The buccal bone and labial soft tissue are also anesthetized by these injections. The target area for deposition is the bone overlying the apex of the desired tooth root. The client is in a fully supine position. The right-handed operator sits at 9 o'clock. Firmly retract the soft tissues. Establish the landmark by estimating the length of the tooth root and the position of the root apex. If available, a periapical radiograph may be used to confirm the length of the tooth root. Apply a small amount of topical anesthetic for 1 minute. Prepare your syringe with a 25 or a 27 gauge short needle, orienting the bevel of the needle towards the periosteum. Direct the syringe parallel to the long axis of the tooth. Insert the needle a few millimeters beneath the mucosa until the tip of the needle is at the apex of the tooth root. Injection depth varies depending on vestibule height and the length of the tooth root. However, in most cases, the needle need only be advanced a few millimeters. If bony contact is made, withdraw the needle 1 millimeter to minimize client discomfort during injection. Aspirate, and if negative, slowly deposit 0.6 to 1.8 milliliters of anesthetic solution. Volume is determined by the individual tooth. For example, multi-rooted teeth will require more anesthetic. Volume is also affected by whether or not the client requires pulpal or soft tissue anesthesia. More anesthetic will be needed to fully penetrate a nerve and anesthetize all of its nerve fibers. An in-depth discussion of this principle can be found in many textbooks on local anesthesia. Once the solution is deposited, slowly withdraw the needle and safely recap.
The anterior superior alveolar field block injection, also called the ASA nerve block injection, is used when multiple dental procedures are planned on maxillary anterior teeth, as well as their associated buccal hard and soft tissues. The efficacy of this injection technique lies in the convergence of the nerves that innervate these teeth. The maxillary sinus posteriorly and nasal aperture medially form anatomical barriers which result in the convergence of these nerve fibers near the apex of the maxillary canine. Therefore, precise deposition of anesthetic in this region provides local anesthetic to the central, lateral, and canine teeth and their surrounding structures on the side injected. However, it is important to realize that there may be crossover nerve innervation to the central incisor from the contralateral anterior superior alveolar nerve. The needle is initially advanced parallel to the maxillary canine and then redirected horizontally to allow contact with periosteum. The final position of the needle is just medial and superior to the maxillary canine. The tissue is dried and topical anesthetic placed. A short 25 or 27 gauge needle is recommended for this injection. The lip is retracted and the tissue pulled taut over the maxillary canine to be anesthetized. The point of needle penetration is high in the vestibule, just above and medial to the apex of the maxillary canine. After initial penetration of the alveolar mucosa, a few drops of local anesthetic are deposited and 5 seconds allowed to elapse before advancing the needle. The needle is advanced incrementally toward the medial aspect of the canine apex, depositing local anesthetic ahead of the needle. Periosteum will be contacted after a few millimeters. Aspiration is performed, and 1 milliliter of local anesthetic solution is deposited slowly over 1 to 2 minutes. Supplemental local anesthetic should also be considered for the maxillary central incisor if unilateral ASA field block injection was administered. Conversely, if bilateral ASA field block injections were administered, supplementation is not necessary.
The middle superior alveolar, or MSA injection, is an infiltration type of injection that innervates the pulpal and osseous tissues, periodontal ligaments, buccal gingiva, and vestibular mucosa of the maxillary premolars and the mesiobuccal root of the first molar. Palpate the zygomatic alveolar crest to determine whether or not you might hit bone prematurely. Determine the apex of the maxillary second premolar. Place topical at the mucobuccal fold above the maxillary second premolar for 1 to 2 minutes. While the topical is in place, use both hands to obtain and ready your syringe, making certain that the bevel is toward the bone and large window toward the operator. Follow all steps and procedures presented in the video clip entitled Basic Steps in the Administration of Local Anesthesia. A 25, 27, or 30 gauge short needle works well for this injection. To gain access to the site of penetration, gently retract the tissue, pulling the tissues taut while lifting the tissue away from the maxilla. The penetration site is at the height of the mucobuccal fold over the maxillary second premolar. If it is difficult to keep the syringe parallel to the long axis, penetration can be made between the two premolars, angling distally towards the apex of the second premolar. The pathway of the needle follows as parallel as possible with the long axis of the tooth above the apex of the second premolar. The depth of insertion is approximately 5 to 8 millimeters, depending on the apex of the tooth. Aspirate at the deposition site. Deposit a half to 2/3 of a cartridge over a period of not less than 30 to 45 seconds. Remove the needle gently and make it safe by properly recapping. Potential complications from this injection are minimal. There is the possibility of discomfort if periosteum is contacted. Be sure to stay parallel with the long axis of the tooth to avoid such touching of the periosteum. Ballooning of tissue may occur in this region. Also, it is possible to see some hemorrhage at the site of penetration. Troubleshooting the MSA injection. When administering the MSA injection, the zygomatic bone is frequently located in that area and obviously cannot be moved. Advancing the needle any deeper is impossible in that case. Because the needle is inserted at the height of the mucobuccal fold, is in close proximity to the root apex, and the maxillary bone is rather porous, anesthesia will be possible to achieve in that area. Therefore, continue with the injection. Deposit the anesthetic slowly and consider depositing slightly more anesthetic than usual, 3/4 to a full cartridge, since the bone is thicker in that region. Be aware that ballooning of tissue may appear in this situation and is normal to observe. Be reminded that the MSA nerve is absent in a large percentage of the population. Exact numbers are not known, but estimates of its absence range from 28 to 72% among authors. Because it is impossible for clinicians to determine if the MSA is present or absent, they must assume the nerve is present. Even when present, the MSA nerve may or may not provide innervation to the mesiobuccal root of the maxillary first molar. It is possible that fibers from one or any combination of the MSA, ASA, and PSA nerves may provide innervation to the mesiobuccal root of the maxillary first molar. From a practical standpoint, this issue is irrelevant. Clinicians routinely administer an infiltration directly over the mesiobuccal root of the first molar in addition to the PSA, or infiltrate over both buccal roots of the first molar to assure a complete blockade when working in that area.
This injection anesthetizes the pulp along with the buccal bone and soft tissue of the maxillary molars. The posterior superior alveolar, or PSA nerve, is a branch of the maxillary division of the trigeminal nerve. After the maxillary division of the trigeminal nerve exits the cranium via the foramen rotundum, it splits into several branches, including the posterior superior alveolar nerve, the infraorbital nerve, the greater and lesser palatine nerves, and the nasopalatine nerve. The posterior superior alveolar nerve provides sensation to the maxillary molars and their buccal periodontium. In some cases, The mesiobuccal root of the first maxillary molar receives innervation from the middle superior alveolar nerve. The PSA nerve enters the maxillary bone through several small foramina located on the infratemporal surface. The target area for this injection is the infratemporal surface of the maxilla. It is important to note that there is also a superior dental plexus of arteries and veins that correspond to the nerves. These blood vessels make this injection site highly vascular and contribute to higher incidence of positive aspiration. The target area for the needle tip is above and behind the second maxillary molar. Direct the needle towards the mid-sagittal plane at a 45-degree angle while simultaneously directing it superiorly at a 45-degree angle to the occlusal plane. The intraoral landmarks for this injection are the zygomatic arch, the height of the maxillary vestibule, and the second maxillary molar. The client is fully supine with the maxillary occlusal plane perpendicular to the floor. For the right PSA, the operator sits at a 9 o'clock position. For a left PSA, the operator sits at 9 o'clock with the client turning their head to the right side. Prepare the syringe with a 25-gauge short needle, orienting the bevel towards the bone. In the case of a right PSA, the bevel should be to the right, and for the left PSA, the bevel should be on the left. For this injection, it's helpful to have the client partially close and deviate their mandible to the side of the injection. This improves the field of view, allows for better retraction, and facilitates the ability to maintain the required 45-degree angulations. Palpate the zygomatic arch. The penetration site must be posterior to the zygoma. Feel for a soft area behind this bony landmark. This is the injection site. Firmly retract the soft tissue until taut and the insertion site is visible. Insert the needle and advance approximately 16 millimeters. No bony contact is made. This region of the maxilla is highly vascular. As an extra precaution, multiple aspirations should be performed prior to depositing any anesthetic solution. Roll the barrel with the fingers to change the orientation of the needle bevel before each aspiration. If there is no evidence of blood in the cartridge after 3 aspirations, you may proceed to deposit the solution. Note the syringe angle. To achieve the 45-degree angle towards the mid-sagittal plane, visualize that the needle tip is directed towards the inner corner of the eye on the opposite side of the injection. After depositing 0.9 to 1.8 milliliters of solution, withdraw the needle and safely recap.
Establishing a stable fulcrum is relatively easy for injections given on the same side the clinician is seated. When giving injections on the opposite side, challenges arise, especially for PSA injections. Taking time to establish a grasp that provides the stability, angulations, and access necessary for the injection can reduce this challenge. Notice that when the palm is facing the clinician, it is very difficult to establish a 45-degree outward angle without compromising ergonomics and leaning well over the patient. One solution to this is to hold the syringe in a palm-up position. This will align the syringe at the desired 45-degree outward angle as demonstrated here. Looking more closely, note that the syringe is balanced between the fingers and the palm is facing upward. This will allow the clinician to maintain both proper ergonomics and injection angles. Consider the same challenge for an IA injection on the opposite side. Notice that as with the PSA, when the palm is facing the clinician, it is very difficult to establish an appropriate injection angle without compromising ergonomics and leaning well over the patient. Applying the same palm-up approach as previously demonstrated will facilitate ease of reach, proper angulations, and ergonomics. Additionally, note the use of the little finger for a clinician with a small hand to stabilize the syringe when a finger-to-chin fulcrum cannot be reached. It is commonplace for clinicians to retract soft tissues with a finger during injections. In some situations, this may present an increased risk for needle stick injury, especially during PSA injections. When retracting with a finger, care must be taken to establish a safe distance between the fingertip and the penetration site. Also, care is necessary to avoid needle contact with the clinician's gloved finger prior to penetration. Clinicians with larger hands will find it more difficult to safely retract in restricted areas of the mouth. The mouth mirror provides both adequate retraction and eliminates the risk of needle stick injury during penetration. As demonstrated here, a surgical retractor can also provide safe retraction in restricted areas of the mouth.